So, good evening everyone. I am Dr. Naveen Porwal, your physiology educator on Unacademy, and this is about the subscription. The plus subscription, you are getting the lot of daily live classes. There are so many batch courses. There are structured courses according to different examination. There are various courses which are for your MCQ as well as for theory. There are various live tests and quizzes daily, and unlimited access you will get. And to join plus subscription, physio 10 is my code. If you put physio 10, you get 10% discount. And this is about iconic subscription. This you can also subscribe, and in this you can get the best of Unacademy as well as the best of prep letter. Prep letter, you know, they are recorded lectures. There is question bank, and this is how it look like. These are the features. And after that, coming to our series, yesterday we have finished this question. Okay, so today we'll start discussion from 21, question number 21. Okay, good evening Moksh, good evening everyone. So question number 21 of the series, at the muscle and plate. Good evening Avinash, everyone, good evening. At the muscle and plate, acetylcholine causes the opening of. It causes opening of. Okay, now read the option for that question. Sodium channels and depolarization towards the sodium equilibrium potential. Potassium channel and depolarization towards the potassium equilibrium potential, or calcium channel and depolarization towards calcium, or sodium and potassium channels and depolarization towards value halfway, or E. What is your best correct option? So this is a simple question, very simple, very basic question, but it has a concept behind that. That is why I have taken this as the first question. A. Okay, Moksha, Sukanya, Ananya, Avinash. So all are saying A. So A is correct. Is A correct? So all of you are saying A. At the muscle end plate, acetylcholine causes opening of. You might be remembering your NM junction. What do you think? Only sodium will go, potassium will not come out. Of course, permeability is different. In depolarization, permeability is different. So what should be the answer? Sodium or both? No sir, D. Okay, so now Mox is saying it is D. Yes, answer is D, not A. Now this is the point I want to highlight. See, what happened when there is NM junction? This is your neuron, this is your muscle, and you know there are channels, ligand gated channels. Ligand gated channels, and ligand is acetylcholine. So when acetylcholine is released, this will act like a ligand, and sodium are more outside, so of course they will go inside, and potassium are more inside, so they will go outside, isn't it? So permeability of sodium will be more. You know that if you talk about depolarization and repolarization, this is your RMP, this is your threshold, and this is your action potential. Okay, so in this particular case, if you look about the permeability of sodium, it is like that, and permeability of potassium is like that. This also question came in NEET PG 2018, that what is A and what is B. What is A and what is B? A is showing the permeability of sodium. You can see when depolarization start, permeability of sodium is very high. It's very high. While permeability of potassium is low initially. After that, it becomes very high in case of repolarization. Okay, so this is the diagram given in Ganong and everywhere. This is your action potential, and A is showing permeability of sodium and B is showing permeability of potassium. So both are permeable, not only one. So at the muscle end plate, acetylcholine causes, this is a ligand, it will cause opening of sodium and potassium channels and depolarization to a value halfway between sodium and potassium equilibrium potential. Okay. So remember that it is not only sodium which goes inside, but it is also potassium. So binding of acetylcholine to the receptor in the muscle end plate opens channels that allow passage of both sodium as well as potassium. Sodium ion will flow into the cell down its electrochemical gradient, and potassium ion will flow out of the cell down its electrochemical gradient. Potassium is more inside, so it will flow outside, and the resulting RMP will be depolarized to a value which is halfway between respective equilibrium potential. It will be halfway of the equilibrium potential of the sodium as well as of the potassium. Okay. An inhibitory postsynaptic potential depolarizes the postsynaptic membrane by opening sodium, depolarizes postsynaptic membrane by opening potassium, hyperpolarizes postsynaptic by opening calcium, or hyperpolarizes by opening chloride. What should be the correct answer? This is quite easy one this time. So now this, everyone good, very good. So everyone is saying D. So very good. So you know that we have discussed on the day before yesterday class that local potential or graded potential, or it is also called as electrotonic potential. These are of two types. Either it can be excitatory post-synaptic potential, or they can be inhibitory post-synaptic potential. Okay, so both are local potential, both are graded potential, and both are electrotonic, and this is causing depolarization. Actually, when they summate together, they cause depolarization and convert into axial potential. They causes depolarization, and inhibitory post-synaptic potential cause hyperpolarization. This is very common question for PGI. Nowadays it become one, hyperpolarization. Okay, this is inhibitory. So depolarization can happen because of influx of mainly any cation. It is because of influx of mainly any cation. This can be influx of any anion like chloride, or outflux of cation. So main thing here is hyperpolarization, and here it is depolarization, and both are because local potential graded, so they will not obey. They don't obey all or none law. They don't obey all or none law, and they can be summated also. So these are very important point to remember. They don't obey all or none law, and they can also be summated. On other hand, action potential obey all or none law, and they cannot be summated. So in that, they hyperpolarize the postsynaptic potential, not by opening of calcium but by opening of chloride anion. When anion will go, it will cause hyperpolarization. Okay. Next question, which of the following would occur as a result of inhibition of sodium potassium ATPase? Decrease intracellular sodium, increase intracellular potassium, increase intracellular calcium, increase sodium glucose co-transporter, increase sodium calcium exchange. Every year you will get one or two questions from this point: primary, secondary, active transport, co-transporter. So you must be very much clear about that. D, what is D? D is increase sodium glucose co-transporter. Okay. B, increase potassium. C, increase calcium. C, digoxin. Yes, Divyansh. E. Okay. So Avinash, you are correct. This is talking about which drug? This is talking about which drug actually? Which drug is inhibiting sodium potassium ATPase, and what is the end result of that? So Avinash is correct. It is mechanism of action of digoxin. When it inhibits sodium potassium ATPase pump, okay, suppose this is your heart. This is your heart, and this is your sodium potassium ATPase. It is coming sodium outside and potassium inside. Okay, and this is calcium sodium exchanger. It is bringing calcium out and sodium in. Sodium calcium exchanger, NCX. This is called as NCX. So if you inhibit sodium potassium ATPase, decrease intracellular sodium or increase. Now sodium cannot be taken outside, so there will be increase intracellular sodium concentration, not decrease. Okay, increase intracellular potassium. No, this pump is taking potassium inside, so now there will be decrease intracellular potassium concentration. Okay, third is increase intracellular calcium. Yes, if you inhibit that pump, this calcium cannot move out, so intracellular calcium will increase, and this is happening in the heart when you give digoxin, that cause positive inotropic action, that cause positive inotropy, or that increases force of contraction. Okay, so in this way it is causing increase force of contraction or contractility, increase sodium glucose co-transporter. So let me talk about this also. In proximal convoluted tubule, on the basolateral membrane there is sodium potassium pump. Okay, and on the lumen of this side there is SGLT. Sodium is coming as well as glucose is coming. Sodium is coming as well as glucose is coming. So this is primary active transporter and this is secondary active transporter. Okay, so if you inhibit that pump, this secondary active transporter will be inhibited. So entry of sodium and glucose will be increase or decrease? It will be decrease. So glucose absorption will be decrease. Increase sodium calcium exchange? No, it will decrease. I discussed in harder previously. So you can see answer is C. Okay, it will increase intracellular calcium. Are you getting me or not? So you must remember that the concept of primary active transporter and secondary active transporter is very simple. Primary are mainly which one? Sodium potassium ATPase pump. Okay, then there are proton pump, then there are sarcoplasmic endoplasmic reticulum calcium ATPase. There are so many pumps. In this there are antiporter and uniporter. You can say co-transporter and counter-transporter. Co-transporter and counter-transporter. Okay. Co-transporter like SGLT, sodium glucose transporter, like sodium amino acid transporter. These are in the same direction. And counter are opposite like NCX, sodium calcium exchanger in the heart. Okay. And these are also using ATP of primary. So if you block the primary pump, they will not act properly. Okay, so this is the concept behind this. Which of the following temporal sequence is correct for excitation contraction coupling in the skeletal muscle? Please read it and tell me what is the correct answer. You have 30 seconds. In 30 seconds you have to read it and tell me the correct temporal sequence of excitation contraction coupling. Yes, Avinash, Moksh. B. Action potential in the muscle membrane. Depolarization of the T tubules. Release of calcium from reticulum. Okay, good. Aman Agrawal B. Okay. So you know about this, you know very clearly about that. This is your T tubule. This is your sarcoplasmic reticulum. There are two receptors on this. What is this two receptor called as? One is called as dihydropyridine receptor. Other is called as ryanodine receptor. Okay, in the skeletal muscle from T tubules, what comes? Action potential or calcium also come in the T tubule. In case of skeletal muscle, my question is that in case of skeletal muscle, what is coming from T tubule? Only action potential or action potential as well as calcium? Only action potential. Okay, in case of cardiac muscle as well as smooth muscle, what is coming? Not only action potentials are coming, but also extracellular calcium is also needed. That is called as calcium induced. That is called as calcium induced calcium release. That is called as calcium induced calcium release, and that will cause excitation, and that will lead to physical coupling. And then there are various calcium molecule inside which is entangled by a protein. What is that protein called as? What is that protein which is, combining all together? It is called as calsequestrin. It is called as calsequestrin. Okay. Now, when excitation contraction occur, calcium will come from this pump, and this calcium, causes contraction by various steps. And after contraction happen, this will cause influx of calcium by again a pump called as sarcoplasmic endoplasmic reticulum calcium ATPase. Okay, so who can tell me what is the exact mechanism how this calcium binds? Who will tell me what is the exact mechanism? This calcium binds with what? This calcium binds with troponin. Please tell me. This calcium binds with troponin C, and after that it will cause conformational change. Conformational change that will uncover myosin binding site on actin. That will uncover myosin binding site on actin filament, and this will lead to actin myosin. Yes, Avinash, bind to troponin C, and thus it causes conformational changes. Yes, very good. And it uncovers myosin binding site on actin, and that will cause contraction. So you might be remembering that this is your actin filament. What is this called? G actin or F actin? If there are polymer actin, what is this called as? If there are polymer actin, what are these called as? G actin or F actin? G means monomer and F means polymer. Remember GF, it is not GH. Okay, and the protein which wrap around, what is this protein called as? The protein which wrap around this actin filament, this is called as tropomyosin. Tropomyosin, and this tropomyosin has attached troponin C. This has attached, what is this called as? Troponin. This is called as troponin C, and when calcium comes and bind, okay, it will cause conformational changes and it will cause actin myosin binding. And when calcium goes inside, it is by sarcoplasm. Okay, now who will tell me what is Brody's myopathy? What is Brody's myopathy in this diagram, and what happened in that? And what is malignant hyperthermia? What is Brody's myopathy and what is malignant hyperthermia? Yes. Ryanodine mutation is what? If there is mutation of ryanodine, what is that called as? If there is mutation of ryanodine, what is that called as? If there is mutation of ryanodine receptor, what is that called as? That is called as malignant hyperthermia. Yes. what is Brody's myopathy? What is Brody's? Dihydropyridine? No. If this pump is not acting properly, this Sarka, it is not dihydropyridine. When this is not working properly, it can cause Brody's myopathy, and calcium cannot go inside easily. And when calcium cannot go inside easily, relaxation will be hampered. So after exercise, you have to relax a bit, and then only you can cause contraction. Center core disease. Okay. So there are so many diseases. And what is drug of choice of malignant hyperthermia? What is the drug of choice of malignant hyperthermia? It is not fever, so you cannot give paracetamol, brufen and all. The drug of choice is dantrolene. Drug of choice is dantrolene. Okay. So this is the drug of choice of, yes, very good, it is dantrolene. Good. So you can understand here that action potential in the muscle membrane, then depolarization of T tubule, release of calcium from sarcoplasmic reticulum is the correct sequence. You can see here. You can see the correct sequence. This is the sequencing. Okay. So next question is very easy. Which of the following transport mechanism is involved if transport of glucose from the intestinal lumen into small intestinal cell is inhibited by abolishing the usual sodium gradient across the cell membrane? Similar thing we discussed just now. What is that called as? If you inhibit sodium gradient, who is taking use of the sodium gradient by sodium potassium pump? Which type of transporter? Okay, this is talking about which transporter? What is the name of that protein, carrier protein? What is the name of that carrier protein? Yes, it is talking about SGLT. So many times I have talked about this. This is very important carrier protein. Okay, so if you inhibit sodium potassium pump, okay, so glucose will not be absorbed because you are inhibiting co-transporter SGLT. And you might be remembering about this, that this is of two types. What is that two types? Yesterday also I discussed this point. These are of two types. What are these two types? One is of course SGLT1, SGLT2, which is also present in intestine, 1 or 2. This is the example of secondary active transporter, co-transporter, not only secondary active but also co-transporter, not counter. Counter is, example of counter is NCX, sodium calcium exchanger. Yes, very good. SGLT1 is also found in intestine and in kidney, both are found. Which has more affinity, SGLT1 or 2? Which has more affinity? Yes, you are correct, Avinash. One is present everywhere, 2 only in PCT. Which has more affinity? 1 or 2? Yes, Mox 2, Himanshi 2, Mehak 1. See, 2 has more affinity, less capacity. You are just telling opposite of that. 2 has less affinity. 1 is having more affinity and less capacity. 1 has more affinity. That is why it is present in S3 segment of PCT and less capacity, only 10%. It reabsorbs only 10% of glucose. It reabsorbs only 10%. So capacity is less, of course, but affinity is very high. It does not allow a single molecule of glucose to pass from PCT. Okay, and SGLT has, although less affinity but very high capacity, more than 90% is present, high capacity, more than 90% of glucose is absorbed by SGLT. Yes, concept is that only. Yes, concept, Moksh, concept is that only. Suppose this is your PCT and you know it has three segment. One is called as S1, other is called as S2, and this is called as S3. Okay, which one is present in which segment? Tell me first. SGLT1 is present in S1, S2 or S3? What do you think? SGLT1 is present in which segment of PCT? Tell me. SGLT1 is present in which segment of PCT? S1? No. On this segment, SGLT2 is present because it needs. This question was asked in JIPMER. SGLT2 is present. SGLT1 is present in S3 mainly because it reabsorbs more than 90% of glucose. So maximum glucose is reabsorbed by initial one third of the PCT, and whatever be left, it will be reabsorbed by SGLT1. So it must have high affinity. Are you getting me? It must have high affinity because you don't want any sugar to go beyond this point. So this is like very sensitive. Okay. Capacity is very high of SGLT2. That is why in diabetes we give SGLT2 blockers because we want to inhibit glucose reabsorption. So you might be knowing about those SGLT2 blocker like canagliflozin and all. You must be knowing about that, like canagliflozin, dapagliflozin, okay, empagliflozin. These are very well known drug, FDA approved drug, which is used in type 2 diabetes, so that if you block SGLT2, maximum glucose will go out, and this will decrease your blood glucose value. Now why this drug is very good drug? What is the main cause? Why we are using this drug now as a first line drug along with metformin? Some recommendation is showing that along with metformin you can use SGLT2 blocker. What is the main cause? Why these drugs are very good drug? Because initially we are using sulfonylurea and all. Sulfonylurea is also a good drug because it is a cheap drug. It is not that costly. It is a bit costly, but these are excellent drugs. What is the cause? Because type 2 diabetic patients are usually obese, and these drugs, when losing glucose, they cause weight loss. Although this drug should not be given in a patient who is having recurrent UTI. Okay, there is more chances of Fournier gangrene, more chances of limb amputation, but they are very rare. Otherwise these drugs are excellent drug. We don't use. Okay, what is the drug which has dual blocker, SGLT1 as well as SGLT2 blocker? Which drug has both effect? Sotagliflozin. Okay, among all these gliflozin, which gliflozin has increased chances of limb amputation? Canagliflozin, depa, empa. Among all these SGLT2 blocker, which has more chances of limb amputation or Fournier gangrene? These are all your repeated MCQ. Which one? Cana, depa, empa. Empa. No, it is Cana. Canagliflozin. Although this is a very rare, rarely seen, but for exam purpose you should know, canagliflozins are associated with increased limb amputation. Okay, so these are your previous MCQ. Coming to the next MCQ, that In a skeletal muscle, which of the following event occur before depolarization of the T tubules in mechanism of excitation, contraction, coupling? Even before depolarization of T tubule, what is happening? What is the answer? What is happening even before excitation of T tubule? Depolarization of sarcolemma membrane, opening of calcium, release on circular uptake of calcium, binding of calcium. What is the answer? It's very simple one-liner question. Of course, before going inside the T tubule, you have to cause depolarization of sarcolemma membrane. You have to depolarize sarcolemma membrane. So answer should be A. Answer should be A. Okay, now these questions have been done yesterday also. So thank you for today's session. It was only half an hour session. Tomorrow will be the last, I think, in the sequence. Then I will start taking special classes on Unacademy. So from tomorrow we can start taking. It is disturbing. Okay, let me. So you can just follow me there so that you can get link of all the classes which I am taking. So on Unacademy we are doing these special classes. Whatever topic you want, you can just comment me. And if you like this video, today any class. Actually, today I am having some other classes also. If I get time, I can take one class from 10 p.m. Let me see if I get time. I will launch that and I will allow it, and I will just inform you all. Okay. So thank you, thanks all, and if you like this video, please like it, subscribe to Unacademy. Thank you all of you.